So, I mean, if you think about it, natriuretic peptides are probably the most strongly recommended biomarker of all in the heart failure guidelines. It has a recommendation for diagnosis of heart failure, for prognosis determination in heart failure, and also at the time of discharge for management trajectory of the patients as well. Having said that, I mean, it's really a simple blood test, like all the other simple blood tests we do, like, hemoglobin or creatinine. I mean, it's really nothing more than that. And yet the use both is sort of erratic and inconsistent, and even with that, suboptimal, and we don't do it nearly enough and in the right patient population and consistently as we should. So I think we get a ton of information from these patients, and now with the strong HF, selecting the patient on the basis of natriuretic peptide gives us further impetus that we should really make some sort of protocols within our healthcare system that the appropriate patient gets this testing whenever it's indicated.
It's been known for quite a while that concentrations of NT-proBNP in the course of intensified heart failure treatment tell us numerous things. First of all, the trajectory of NT-proBNP after intensified heart failure management tells us a large amount of information about the subsequent prognosis of the patient. In the guided HF study, by 90 days, if a person was not under 1,000 picograms per milliliter, NT-proBNP, their risk for heart failure hospitalization or death was anywhere from 60 to 75% higher than people who were below this threshold value. So right immediately we can see how this biomarker can inform important things about the subsequent prognosis of a patient. But we've learned a lot more since then. First of all, more significant reduction in NT-proBNP in the guided study, as well as in other trials, including the PROVE-HF study, shows that the more significant reduction in NT-proBNP is associated with greater amounts of reverse cardiac remodeling, improvement in ejection fraction, as well as greater improvements in health status, a greater improvement in the Kansas City Cardiomyopathy Questionnaire score, for example. It's not just about event rates, but also important clinical factors that matter to the patient and to the managing clinician. Left ventricular function improvement is something that we would need to get an echo to see. If I have a patient sitting in my office at the Mass General Hospital Heart Center with a steeply negative trajectory in their NT-proBNP, I am confident in the knowledge that their left ventricular function is improving. So the ACC Expert Consensus Decision Pathway document for heart failure management recommends an NT-proBNP along with usual laboratories every 3 months for stable patients in order to monitor clinical stability, left ventricular remodeling, and other variables. Now, we have data that we're presenting at the American College of Cardiology meetings where we looked at the serial measurement of NT-proBNP among individuals with heart failure with reduced ejection fraction. And we asked a simple question, which is if we take all of the measurements that were taken in this group of patients, several thousand measurements of NT-proBNP, and look at those individuals who have clinical events versus those who do not, what we're able to show is that NT-proBNP concentrations tended to start rising weeks to months before the event occurred, really illustrating for clinicians how serial measurements can help to inform the likelihood of events that may be months away, allowing for the clinicians to be responsive and nimble in their therapeutic decision making.